So I thought it'd be useful to start just by framing the numbers really around the number of people that have actually had a leader review since it all started in 2018. And as you can see, this slide represents well over 3,000 people that have died with a learning disability, and autistic people have been reviewed under the leader programme. And I thought it would be interesting for you just to see a snapshot of how the reviews have come in over that time period. And you can see that the graph is split between adults and children. And also you can identify that there were peaks at the key times of COVID-19, which were basically around the March-April period in 2020, and in a similar period just before Christmas and January 2021. And overall, in terms of nationally, and this is taken from data that was crunched in 2021, you can see that 56% of people that died were male and 44% were female. So that just gives you an idea of what sort of cohort we're basing information on. Can I have the next slide, please? So drilling down a little bit, because we've also looked at deaths in the southwest of England analysed the numbers. You can see in the southwest, we basically of the number of deaths that have been reviewed have made up 10% of the total national number. So in the southwest of England, we've had a total of 336 deaths that have been reviewed under the leader programme. 313 of those have been adults, and 23 of those have been children and young people. And again, you can see that the numbers really align in terms of the percentage numbers, in terms of split of male to female, reflect that which happens in the national picture. And we've got slight variation in terms of average medium age of death between male and female, and that males in the southwest of England have a median age of death of 61 years and females 58.5. So slightly younger than has been found nationally. The other slight variation from comparing our own figures in the southwest around deaths and that of the national team, the national picture, is that we actually also have our median age of death is 1 year younger than the total than the median age of death nationally. It's kind of like in overall, it's not a massive variation, but it's something just to recognise. So can I have the next slide, please? So I thought very quickly I'd give you just a snapshot of the 5 most significant long-term conditions occurring compared to the national picture and the regional picture. And you can see that nationally, epilepsy is one of the most significant long-term conditions occurring in individuals that died out of the up until 2021. And regionally, based on 2021 numbers, it's the second most significant long-term condition that people are actually living with. So 37% of individuals that were reviewed under the leader programme had epilepsy. Next slide, please. In the context of people dying younger, we can actually see that there are some key influences into when we've looked at the data. So epilepsy, people living with epilepsy or previously treated for a deep vein thrombosis were amongst those in the cohort of individuals that tended to die younger. Sadly, also, that's the case with people that were from a minority ethnic background. They seem to still experience a double whammy of health inequality under when we look at the information under the leader programme. And lastly, where an individual didn't die either in hospital or in their usual place of residence, there's usually they also were found to die younger. Next slide, please. So the question is, in terms of specifically around epilepsy, I mean, the National Leader Programme is taking lots and lots of actions around making improvements, as we are in the southwest of England. But specifically around epilepsy, there are a couple of pieces of national work being done. There's going to be an academic deep dive this year that finishes in spring, looking at the factors that contributed towards the earlier death, particularly in young people, which is being done by the King's College London in partnership with the University College Lancashire. I always get that wrong, the UCLA. Also, there are the national team have commissioned have commissioned a piece of work to actually develop additional resources to support knowledge and risk tools around sudden unexpected death from epilepsy. So they're looking at exploring the use of an app. Gosh, I'm terrible with technical stuff. So they're looking at developing an app called the Epsmon, and see if it can be made accessible, more accessible for people with learning disability. Bearing in mind that a lot of people that have a learning disability tend to be less digitally savvy than your average bear, although I would say I was probably amongst those as well. And also they've trying to develop a number of leaflets and videos to support people and their carers around awareness around SUDEP. Next slide, please. This is my last slide. It's short and sweet, but in terms of what we're doing regionally, next year, as in financial year from April, we're hoping to do a piece of work. I plan to do another call to action event. We had one for dysphagia this year and some work's come out of that. But this coming financial year, we're hoping to have another call to action to basically bring people together to help us understand what we might do from a Southwest perspective in terms of taking at least one action to improve the situation for people living with epilepsy in the Southwest of England. So that's hopefully I've got some money to support that. I'm smiling because my the head honcho is on the call, and hopefully he's listening to what I'm saying. So now I've said it in public, that puts some weight on my case. So hopefully then we'll be able to do something constructive across the southwest of England with colleagues to try and develop at least one thing that will improve things for people with epilepsy. So it's short and sweet. There isn't a great deal of information specifically around epilepsy within current leader data. There will be more once the deep dive is done, and I'm very happy to come back and or share it with people then. But for now, any questions around what I've said or anything as part of the Health Qualities Programme?
Thanks very much, Nicky. That was really helpful. I think just highlighting what the national team are doing, you know, the fact they're going to be considering that deep dive from the University of Central Lancashire. I always have to think about that one, and King's College as well, and looking at the app. It's also interesting to hear about the calls for action. So that's something perhaps going forward we can raise awareness of with other people. I see that Lorna Jones, you put your hand up. Apologies, I didn't specify earlier about questions. Would you like to, Lorna? Would you like to ask a question? If anybody else wants to ask Nicky, this would be a good time. We've got some time for discussion, but because Nicky's presentation was quite brief, we've got a bit of time here.
Oh, hi, yeah.
Oh, yeah.
Sorry, I actually meant to put a thumbs up and press the wrong button.
Oh.
So, no, that was really, really interesting. Thanks ever so much.
Thanks, Lorna. Okay, well, thank you. Well, if there are no other questions at the moment, I can see Anna's saying that she's really interested in the work. If you've got any other comments, please put them in the chat. We'll have some time for discussion later, but it may be as Anna and Geri present, you'll think of some other things you want to ask Nicky. So please include those in the chat so we can make sure we cover them. Thanks. Next slide, please. So I wanted to briefly raise awareness of this. Alongside my role with NHS England, I'm also a clinical coordinator at NCPOD. It's the National Confidential Inquiries into Patient Outcomes and Death, which sounds a bit kind of highfalutin, but actually it's a really practical response to clinician raised concerns. And so the management of epilepsy was raised with problems some years ago. And because of that, the report has just been published called Disordered Activity. I know this is a very busy slide, but the bit on the right is just a very brief overview if you want to go and have a look at it. But there are a number of recommendations that were made for people with a learning disability, that the usual epilepsy team should be contacted if somebody's presented with a seizure, think about inpatient reviews, record the medications and investigations if somebody presents with epilepsy, and share follow-up plans. So all of that's relevant to the general population, but it's also very relevant to our population of people with a learning disability. And absolutely key to this work was the involvement of the epilepsy specialist nurses. And as a GP, I can't emphasise enough how important they are to my work. So with that, I'd like to hand over to Anna and Geri to give us an overview of epilepsy nursing. Thank you.
Thank you. So I'm Anna. I'm an epilepsy specialist nurse at Southmead, but I'm a learning disability nurse by background, and in my last role I was a leader reviewer as well. This is Geri.
Hello, I'm Geri. I'm one of the epilepsy surgery AMPs at Southmead Hospital.
So there's 4 of us at Southmead, 2 epilepsy specialist nurses and 2 epilepsy surgery advanced nurse practitioners. We've also got 4 epileptologists, which is consultant neurologists with a special interest and expertise in epilepsy. And we've got a clinical fellow in epilepsy, other neurologists, and a neuropsychiatrist with an interest in people with epilepsy and LD as well. So Alison asked if we could give you some information about when it's appropriate to contact us and refer to us. So the nurses are involved with people only if they're already known to our service, and our contact details for those patients or professionals involved with them is up there. And we want people to get in touch if they're having any side effects, any continuing seizures, any problems or queries around their epilepsy or their medications. You can contact us. We'll get back to you as soon as we can with quick advice. There is a number for GPs to ring, and that's on Remedy. And they can go through to neurology to get quick advice and guidance from that as well. We don't provide basic training in epilepsy. There's lots of really great places that you can get that from, but we do, for people who are known to us in the clinic consultations and everything like that, we do more bespoke training around that person, their epilepsy, and how to manage it. So this presentation is going to be a really quick overview, so I'm glad that that other one was that Nicky was a bit quicker, so that we can steal a bit of the time maybe, if that's allowed. But we'll share the presentation afterwards, and in the section underneath all the slides, I've added lots of extra information about where you can go for more information and extra reading and links and stuff like that. Next.
Thanks. I think there's one more bit to come up. Yeah, that's it. So first of all, just a quick overview. What is a seizure? What is epilepsy? Seizure is what your body does when there is a uncontrolled abnormal electrical activity in the brain. Oh, sorry. It can be seen as a sensation or a change in behaviour or consciousness. And that's a seizure. Epilepsy is 2 or more unprovoked seizures more than 24 hours apart, or 1 unprovoked seizure and a risk of developing further seizures, so sort of previous brain injuries, that sort of thing, or an epilepsy diagnosis or a diagnosis of an epilepsy syndrome. So everyone's allowed a seizure in their life. About 10% of people do, and they don't go on to develop epilepsy. So that's a seizure and epilepsy. Next slide, please. So this is just the new terms for the seizure classification. So you've got focal onset, generalised onset, or unknown onset. So your focal onset, so your complex partials, they were before. Auras are your aware seizures, impaired awareness are your complex partials. And then you can go in further. There are further sort of breakdowns, but this is just what you would need to know really as a focal onset, whether they were aware or impaired awareness, whether it was a generalised onset and whether it was a non-motor or a motor. And that's just, it's really handy to sort of know that. Yes, so unprovoked would be sort of no known reason. So alcohol withdrawal is a provoked seizure. Illness, that sort of thing would be a provoked seizure. Next slide, please. Oh, can you play the video, please? This is just a video of first aid in the community of tonic-clonic seizure.
I might stop sharing and start sharing again just so I can share with sound. 1 second.
I got loads of work for college and that. Nah, he wouldn't know any better. Besides, it has nothing to do with him.
Sid, it's all right, mate. It's okay. I know what to do. Right, just pop that into your head. There you go. Okay. I'm going to stay with you until it's over, okay? Just going to roll you onto your side, mate, so you can sleep it off. Sid, I'm just going to tilt your head back, mate. There you go, just keep it there for me. You're all right, Zed. It's okay, mate. I'm with you.
I think it's just going over the key parts. Okay, great. Can you go on to the next slide? So that one was for a tonic-clonic seizure where somebody will generally go stiff, fall to the floor and convulse on the ground. So that was the first aid for those. For other seizures, the focal ones, where somebody might present as confused, be making some movements or seem vacant, you want to guide them away from danger, stay with them until they've recovered, keep reassuring them. And if they've missed something, for example, in conversation or educational setting, then explain anything that they might have missed afterwards. You don't need to just restrain someone. The only reason it would be to sort of guide somebody away from traffic or something dangerous, and not to sort of crowd them or act in a way that might frighten them, because they won't understand what is happening at that point. And just, you don't need to do anything to try and bring them around, just stay with them and make sure that they're okay, really, for focal seizures. And the picture that's up there is from Epilepsy Action. On their website, they've got loads of good information about first aid for all seizure types, as do Epilepsy Society. But that easy read about first aid is really, really useful to share with service users and their families as well. Next slide. So thinking specifically about people with epilepsy and learning disabilities, I know Nicky mentioned some of the statistics about this from leaders' perspective. Overall, seizures are the most long-term condition for people with a learning disability, and 1 in 5 people with a learning disability will have epilepsy. And in the general population of people with epilepsy, about a third of them aren't controlled with medication. That's the opposite way round for people with a learning disability and epilepsy. They've got only a third chance of being seizure free with the right medications. So LEADER, almost half of the people who died had epilepsy, and the life expectancy for people with a learning disability and epilepsy, that's reduced from, you know, the already very low age that we know from LEADER, and it's in the early 50s for people with both LD and epilepsy. And people with a learning disability and epilepsy have up to 9 times an increased risk of SUDEP. SUDEP we're going to talk about a bit later. They're also the seizures are the most common cause for avoidable hospital admissions, and it's 40% of all emergency admissions for people with learning disabilities. And we know that polypharmacy is a huge issue for people with learning disability and lots of different conditions. With epilepsy, people with LD on an average of 5 anti-seizure medications. And it was found recently that only about 8% of people with learning disabilities are on the newer drugs that have kind of come out in the last 10, 15 years. A lot of them are on the older seizure medications. Next slide. Yes, the slides will be shared, and I'm happy for them to be shared with other people.
So the seizure risks. So there's lots of risks associated with having a seizure. So injury, you can fall down, hurt yourself, you can scald yourself, you can burn yourself, you can walk into traffic, general broken bones, cuts, bruises, all of those things. Drowning as well, which is why we suggest a shower rather than bath. And you should be with supervision, and the door should be unlocked as well, which is quite difficult when it comes to, you know, like dignity and privacy and things. Convulsive status epilepticus, so that is the status, so that is when a tonic-clonic seizure lasts more than 5 minutes, or you have a second seizure that you go into without fully recovering from the first seizure, or a cluster of seizures lasting more than 30 minutes. Then you have non-convulsive status epilepticus. This is more likely to be seen in people with that you can see. Sorry, I'm mixing myself up with another thing I did yesterday. A change in mental status or behaviour. So if they're not quite themselves, a bit more withdrawn than usual, it may be continuous seizure activity that's going sort of on underneath, and they're just not displaying the seizure, but they're just not quite right. That would be shown up on an EEG and can be treated with some clobazam. Postictal psychosis, so this is different from the postictal confusion, so the confusion that you get straight after a seizure. Postictal psychosis is something that can develop 1 to 3 days after a seizure. So if you have someone that has a cluster of seizures and then a few days later just starts acting a bit more not quite themselves, you know, that's potentially postictal psychosis. Some people have a prescribed PRN antipsychotic because they're known to have postictal psychosis. And it's like I said, it develops later on, so 1 to 3 days, but it can happen 7 days after a seizure. And the other thing is, so you're more irritable, you have insomnia beforehand, and then from that, then you start to be a bit more delusional thinking and hallucinations and things like that. And then SUDEP, so that's the sudden unexplained death in epilepsy. There's a 1 in 1,000 risk of SUDEP every year, just the general population of epilepsy. And then this risk varies depending on seizures. So people with very frequent seizures, it's estimated to be between 1 in 50 and 1 in 100. These are the patients that continue to have seizures, that are young, that are male, don't take their medications properly, and generally might not interact with the services, so they're more likely to have more seizures. So unfortunately, that is, you know, some of the learning disability patients as well.
And sort of tonic-clonic seizures at night.
Yes, tonic-clonic seizures and at night time, and a long tonic phase as well is associated with a higher risk. Next slide, please.
Some of the other risks as well that we didn't mention on there is just generally about people's mental health. Their epilepsy can have a big impact on that, as well as their cognition, and people with epilepsy are at a greater risk of suicide as well.
And memory loss as well, really poor memory.
So what do we do about those risks? So some of the risks that Geri just mentioned about SUDEP, there's some really good risk assessment type things out there for professionals. There's the SUDEP and seizure safety checklist that's available from SUDEP Action. And we'd expect care providers to be carrying out risk assessments for the person with epilepsy that they're caring for, and just asking them to think about their seizure type, and if this person was to have a seizure whilst this was happening, what are the risks and what can we do to reduce those risks? Making sure that people have got the right support in place. So if we don't think they do, it might be a referral to Care Direct and asking for a Care Act assessment. Based on someone's seizures and their risk assessment, they might be recommended some protective equipment, like that helmet that the person's got in the first picture there. And that would be through a referral to orthotics to get something like that. People quite often don't think they look very cool, and there are lots of organisations though that do ones that look like nice baseball caps as well. If somebody is eligible for their care and support needs under the Care Act, then one of the ways that those care needs could be met is through technology enabled care. In Bristol there is a tech team that will go out if someone's got eligible needs and find out about the person's seizure types and see what technology they've got that they would be able to offer that could alert carers to a seizure. So it might be a falls alarm, it might be a bed monitor that picks up on any shaking, it might be a pendant alarm if somebody has an aura to be able to verbalise or let somebody know that they felt like a seizure was coming on. It's unfortunately not something that we've got access to, so it'll be through the council. If somebody has a history of prolonged seizures or clusters of seizures, they could be prescribed rescue medication. So some of you might recognise that syringe at the bottom, buccal-midazolam. And you know, another way to manage risk is just to make sure that people are aware of risks and have training and you know, in epilepsy and how to manage it. And that picture, sorry, on the right is a really useful leaflet from SUDEP Action. They've got one explaining in easy read all the things that increase your risk and what you can do to reduce your risk. So things like taking your medication, avoiding alcohol and drugs, having kind of technology, and it comes with a guide for carers to give further information along with it as well. Next slide. Sorry, yes, the tech team is part of Bristol City Council, and it would go through initially from Care Direct to be triaged by a social care practitioner and see if it was suitable to go to the tech team. So documentation is something that we wanted to include because unfortunately from when people come in with a care provider to their appointments, and you know, it's just the state of the world at the moment that people get sent in with somebody that is their first week, they don't know this person, they were just the only driver that was on that day or something like that. So we ask, you know, we understand the pressures that are on all social care settings and everything, but we just ask that people can be given the right documentation to bring along with them. So bring in their seizure diaries, whatever they look like, whether they're ones that your organisation has made yourselves, ones we've shared with you, or ones from the epilepsy charities, and just giving really clear information about exactly what happened. So being in LD, you're probably all really familiar with ABC charts, and that's really what we want from seizures as well. So what happened before, what was the antecedent, what was the behaviour or the seizure, and what was the consequence of that, what happened afterwards. And thinking about the timing of it as well is really important to know if people have a trend of their seizures getting longer and not stopping. You want to time it for the seizure, so the part that they're convulsing, rather than including the part where they're recovering as well, where they might just be a bit confused afterwards. Video recording can be really useful, especially if there's queries around somebody's diagnosis of epilepsy. And I've put a link in this presentation that will be shared with you to a really useful blog about how to do seizure video recordings usefully and some considerations around capacity as well. Other things that would be really useful to bring to appointments is a medication list. That's quite often not brought. Information on any side effects, so anything that you've noticed about the person that is different since they started taking this medication or increased this medication, or things that you're concerned about, even if you don't think it's related, just so that we can consider it. And any questions that you as a provider or carer or the person with epilepsy has, bring those questions to the appointment so that we can address them.
Next slide, please. So this is just a little one about the medications. So there's loads of medications out there. As we said before, a lot of people that are on that have learning disabilities are on the older ones and on multiple ASMs. So the two that we've just put up there is just the levetiracetam, so the Keppra, and the lamotrigine and Lamictal. I'm sure a lot of people are aware of these two. They're the first line treatments. Most people have, well, everyone should have tried them at some point, if they're on all the others. But, you know, we can help you with titrating these doses. There's newer versions out there. So if a patient or if someone is having seizures still, you can, you know, you need to either speak to the GP, or then GP can refer into neurology, because we can see them. And, you know, just because they're having seizures and it's, you know, possibly unlikely we're ever going to get them seizure free, we might be able to try them on different newer medications. That, you know, there's the Keppra rage, which is quite a common side effect from the levetiracetam, and there's newer versions of it now that don't have as much of those side effects. So we can always try these newer medications, but they'd need to be sort of referred to us first, because a lot of them are either amber drugs or red drugs. Next slide, please. Oh, it's you again.
Okay, so for monitoring of the seizure medications, it's good practice in people's annual health check for them to have blood tests, and that can check for things like liver function. That'd be useful for some of the medications. For people who are on phenytoin, which is one of those older drugs that you might see that is not very nice, it's recommended to have bloods done yearly unless there's a clinical indication. And lamotrigine is a special one in pregnancy that you need to check the levels monthly, as it can go down a lot and need to be increased a lot for that person. And people with learning disabilities living in care provisions, this is specifically important for them about thinking about their bone health. So in these medications, which are enzyme-inducing seizure medications, which you might recognise a lot of them from your service users, if they're not on vitamin D and calcium supplements, then please request it from your GP or suggest it, because it's especially important for people who are maybe wheelchair users or immobilised for long periods, don't have much sun exposure. I mean, vitamin D is recommended in adults throughout the winter anyway, even without these medications, and people who don't have great calcium intake. And we know a lot of our service users might be quite picky with the types of foods that they have. And there's loads of information. Public Health England have got a whole book basically about reasonable adjustments for blood tests for people with LD. And I've just stuck up there. I saw Lynn Sandals was here. I've stolen that from you about having a blood test that was made at MBT.
Okay.
Yeah.
Yeah. Next slide, please. Okay, so drug-resistant epilepsy. So this is when you have ongoing seizures despite trying 2 or more appropriate anti-seizure medications. So I mean, most people, if they're on 5, they've got drug-resistant epilepsy. Now, there is other options for them rather than just medications. They can be enrolled onto the surgery programme. So that's here at Bristol. We see people from Land's End all the way up to sort of Gloucester Way. And you just need to refer into your local neurologist, and then they can refer up to us to be enrolled on the surgery pathway. They'd be reviewed by a neurologist in the first instance. And then we can either, if it's seen as appropriate, would first of all go for the vagal nerve stimulator. So it's a small device that is a bit like a pacemaker. It's just implanted just under your clavicle, and there's wires connected to your vagal nerve, and then that sends electrical impulses up to your brain, which tries to stop the sort of quells the seizure activity. These, we do hundreds of these all the time, and they do tend to have quite good results. So you've got it's the rule of thirds, as most things are. So a third, unfortunately, will have no response. A third will have more than 50% reduction in seizures, and then a third will have a smaller reduction in seizures. The battery changes every sort of 4 to 8 years, and that's done. It's a very quick operation, just a quick battery change. Or if we feel that actually they would benefit from resective surgery, they can go through the whole process of the epilepsy surgery program, where we would investigate them, do quite in-depth scans, find out exactly where this seizure where the epilepsy may be coming from, and resect that area of the brain. It's quite a long process, but you know, we do have good outcomes, and it doesn't matter if you have learning disabilities or not. You know, if it's appropriate for you to be put onto that pathway and get the possible curative treatment of the resective surgery, and it's appropriate, then we can. So yeah, so that's, and then there's VNS nurses in all throughout the Southwest that can then monitor. So once we put it in, we then sort of discharge back to your local team, and they will manage the VNS as well. Next slide, please. Yes. So some other things to consider. Now, this is basically us just going, what about this? What about this? So just to make you aware, and we are here for you to ask any questions if you need to, or if you want to know a bit more. So first of all, we have transition clinics. So that's a joint clinic between the Bristol Children's Hospital and us every month, pretty much. Depends on courses and days off and things. Just to be aware of recreational drug use and alcohol. These are triggers for seizures. The alcohol risk is at its highest 6 to 48 hours after you stop drinking, so the hangover period. Contraception. Some contraceptions do interact with your anti-seizure medications. The coil and the depot are suitable with all anti-seizure medications. There is some good guidance out there from the
Faculty of Sexual and Reproductive Healthcare. There's a link.
There's a link in there, and they've got, you know, that's what we sort of look at. Pregnancy. So encourage your patients to register on the Epilepsy and Pregnancy Register. Folic acid 5 milligrams once a day for the first trimester, and they will be seen in antenatal clinic with an epilepsy nurse. I think it's face-to-face at St Michael's in Bristol, but it's more remotely done when they're at Southmead. At the moment, that was just from COVID, and it's just not gone back yet. As we said before, lamotrigine levels are to be checked monthly, or as advised by the antenatal team. Some anti-seizure medications are unsuitable in pregnancy, but please do not just stop them, refer them in, and we can go through that. And if someone's thinking of getting pregnant, they can be referred into us to have preconception counselling. Anyway, you know, even if they're seizure free, but they just want to think about having a baby, refer them in, that's fine. Also driving, so they can't drive until they've been a year seizure free. That's the blanket rule. There are some exceptions and a bit of this and a bit of that. But that's sort of the blanket rule, and then DVLA have obviously got more information on the specifics of driving. So we've tried to cover everything, which is never going to be possible. So yeah, but we're here basically. The take home, we want the take home to be, you know, we are here. You can contact us, you can ask, you can refer. That's what we're here for.
Thanks very much indeed, Geri and Anna. That was absolutely brilliant. I learned quite a lot, and it made me think about the SUDEP resources. I'm aware of a bit of time, so what I might do is I'll hand over to Carole, and then perhaps if we've got time at the end, we might have a bit of time for questions. Otherwise, if you put it in the chat, we can see what we can do. Because Anna, I see somebody was asking if they could have an example of your seizure diary, whether that might be something we could share afterwards. But while I do that, I'd like to hand over to Carole Buckley, a colleague of mine who's also a parent carer. Carole,
thank you. Thank you for inviting me. And as Alison just said, I do come with multiple hats on, and today I'm talking about being a parent carer, but I am also a retired GP and have been part of the Royal College of General Practitioners, Autism and Learning Disability Services, and have worked with RCPCH. So I'm not your standard carer by any means, but I thought I would introduce you to my son David and take you through the timeline of his epilepsy. And I have a disclaimer, all right? He no longer lives in the Southwest, so if I am rude about any services, it's not the Southwest, okay? So just in case that happens to crop up. So if I could have the first slide, please. So this is my son, David. I'd like you to see him because, as you can see, he's a cheerful, happy chappy. This is on his birthday. He's in his early 30s now. He's at the Yorkshire Wildlife Park. And just to say that his support worker on the right with the bald head and the beard is not a midget. My son happens to be very tall. And if you could show us the next slide, please. That's me on the end. And that's him with his sister in between him. So this is actually quite relevant. The size that David is really quite relevant in involving his story. So next slide. So the timeline for David is that he has a severe learning disability and autism. So around about his 13th birthday, at puberty, he had his first seizure. It was preceded by very aggressive behaviour. It was a classic tonic-clonic seizure. It occurred while we were staying with my brother and his family in very rural Norfolk. So there were several witnesses who were not medical, although my daughter is now a doctor. She wasn't at that point, you know, she was only a teenager herself. So several of the witnesses actually thought he was dying. They'd never seen a seizure before. There was a lot of distress around the family. And being away from home, I didn't have my medical bag with me. I didn't have anything. I didn't have anything with me at all, which made me feel actually remarkably vulnerable. So if I felt vulnerable, I wasn't surprised that David had had a seizure. At least 30% of the Davies of this world will end up having seizures. But it wasn't where I would have chosen for him to have his first seizure. It was only very brief. It was less than 2 minutes, and I didn't really feel that admission would help us at all because he would have been absolutely terrified in hospital. He would have got very distressed, and we weren't really going to gain very much at all. But none of us slept very well that night, it has to be said. Of course, the next day, having had his seizure and his post-ictal phase, he was back to his usual cheerful self, and he wanted to go back to normal activities. He wanted to swim, he wanted to run, he wanted to do everything he normally does. But it has to be said that the rest of the family were significantly struggling at this point. So if we were struggling, one can only imagine that somebody without any medical knowledge would have found that first 24 hours really terrifying. Next slide, please. His second seizure occurred quite soon afterwards, and he was referred to the local paediatric neurology department. He started on Epilim, and dose titration led to eventual seizure control, although it took about 18 months. I have to say, paediatric neurology outpatients was a nightmare. David was already very tall. He's on the 95th centile for height. He was already significantly taller than me by the time he was 13 years old. Pediatric neurology departments have little chairs, which didn't really fit him. They're very noisy. They're very busy. They have little children running around all over the place because they're not just and so David found that environment almost impossible to cope with his autism as well. We also realized that we could predict his seizure behavior, his seizures, because of the aggressive behavior that came beforehand. He's, as you could see from the very first photo I showed you, he's normally a very happy chappy. So that was a bit of a warning that it was going to happen. But it wasn't close enough to the seizures for us to be able to describe it as an aura, so that we could actually predict when he was going to have a seizure. And I have to say, we lived on the edge while we were getting control, because they occurred in several settings, including in the back of the car, which made his father very anxious about taking him out unaccompanied. And that used to be one of Davies' greatest pleasures. And one of the things that my husband could do with him was to take him for a drive, because going for a drive, and particularly things like driving over the Clifton Suspension Bridge with all the lights and everything, was one of his pleasures when he needed to get away and get some space. And the other problem that we discovered was that he almost always damaged himself because he fell from such a great height. And we couldn't predict that this fall was going to happen. So we ended up padding the edges of the television stand that he tended to watch the television on, and making sure there was thick carpeting and cushions about the place and everything like that. Next slide, please. So continuing with his lifestyle and his timeline, in 2006, he left home to go to a specialist college. It was just before his 17th birthday. The residential college was very well equipped to deal with a young man with autism, severe learning difficulties and epilepsy. He was very happy there. He only had very occasional seizures, about one annually at the most, but really, really very good control. So from 2002 to 2009, he'd really, after we'd got initial control, done extremely well. Then in 2009, he had 3 seizures in under a year. And his medication hadn't actually been altered since 2004, and he had continued to grow at pace. So he was even taller than he'd been when he first started having seizures. This is the point where I stressed that he wasn't in the Southwest then, because the consultant really had to be persuaded that more could be done, as he still felt that this was good control for someone like David. And this was despite the evidence that showed that poor seizure control was one of the greatest risk factors for SUDEP. And I took the phone call at work, where I used to work with Alison, where I got really quite angry and pointed out that he was 20 years old and would normally be driving, and he wouldn't have been able to drive because of these seizures, and something needed to be done. It has to be said that after appropriate medication review, we once again gained excellent seizure control. The consultant is a learning disability consultant, and I think there are some learning needs amongst some areas of specialist services. Just throw it out there. We can maybe talk about it later. Next slide, please. In 2013, he moved to a residential unit with 2 friends from the college. He's still there. The staffing ratio is 1-to-1 indoors. They have waking night staff. Of the 6 young men on David's unit, 2 of them have seizures, and they have 2-to-1 support when they're out of doors. This is obviously quite costly, but he is very happy. And the 2-to-1 outdoors is really because of the relative risk of a seizure or behavioural problems. You were talking about technology, he had a seizure alarm under his mattress, but has had no night seizures at all since moving there in 2013, so that's now been removed. His seizure control is really very good now. His last seizure was in February 2020, so 3 years ago. He still tends to injure himself because he falls from such an enormous height. He's about 6'4". In 2019, he had a seizure and sustained a head injury and had a palpable lump on his head. The paramedics took him to Doncaster A&E. I've now given away truly where he lives, as he was in the Yorkshire Farm Park and Doncaster A&E. But I have to say, in Doncaster A&E, he received absolutely exemplary care. The paramedics came to the unit because of the head injury. He was recovering by that point. They waited until he'd recovered, and he allowed them to examine him. They decided he needed to be transferred to A&E. We were informed of the need for transfer. They allowed him to have a snack before he went, because that's quite important to David. By the time they got to A&E, he went in the ambulance with a carer. The A&E department knew he was coming. He was taken straight through and into a side room, and a doctor who was obviously very experienced came in and saw him immediately. The whole situation was dealt with, and he came back home and had his tea. The whole thing took about an hour, and it was how good care for somebody like David can truly happen. In 2020, when he had the seizure, the paramedics did actually speak to me, because they thought he might need to go in, but after we'd discussed it, it was agreed that transport to hospital wasn't needed. I have to say, I think that's only because I confessed up to being a GP with a particular interest in epilepsy. And I have to say, David has never needed rescue medication. So that is a really quick go through. Next slide, I think, is big questions. David's timeline, which really fits in very well to what our last speakers were talking about, and does really, I think, demonstrate some of the issues that might arise. I think we, as professionals, don't always truly appreciate how frightening epilepsy is for carers. You know, when I talked to my family after the first event and talked to my daughter, who's now a doctor herself, they were so frightened. It was extraordinary, really, that because they truly thought he was dying. And I think we probably don't understand that as well as we should. And the work I did with RCPH was around writing leaflets for parents after a child's first seizure, which goes into a lot of the stuff that you've just talked about, you know, positioning and what to do, and the fact that actually they're not usually dangerous, but when it might be dangerous, and that sort of thing. So that's me done. Happy to answer any questions. Hopefully that was what Alison wanted of me. Okay, thank you.
Thanks, Carole. That was fantastic, and it was what I wanted, actually, because we were hoping that you could share what happened to David, but also your description of the bewilderment and how families feel frightened, even though you're really experienced. Just it magnifies what it is for everybody else, and that for people who haven't been to our webinars before is why we're really keen to have carers speak to give us that additional perspective. And actually, I think, as I said to Carole, I saw her a couple of weeks ago, one of my colleagues at one of the places I work, he had his first tonic-clonic seizure in front of everybody. And actually, it was quite bewildering for the general group within the working setting. I'm really aware of time, so I'd love to have said we'd have time for questions, but I'm also aware that we need to finish for 2 o'clock. So if you've got something you want to ask, could you put it in the chat and we'll see if we can reply with those questions. And I apologise for doing that, but I think I hope you found it really helpful. Nicky for the context, Anna and Geri giving the really practical hints, and particularly the video on actually how to manage somebody who's having a tonic-clonic seizure. If we can share that alone, just, you know, looking after somebody, and then Carole with those insights. If I could have the next slide, please. Before we finish, I just want to let you know that there's been some great resources developed by the regional team on constipation in children. So please have a look at this. We always like to share good news. It will be in our newsletter, but have a look at what's there. There's some great videos on constipation and lots of other resources for clinicians. So with that, I'd like to say thank you to all our speakers. Thank you to everybody for joining us. It's interesting, we had nearly 80 people have come, which is incredible because people have just joined at the last minute, and particularly with all the pressures that we know that's going on with all the industrial action and other challenges. We're really grateful to you for joining us. So our next meeting, we're just planning, it's probably going to be on dementia. There's quite a lot going on at the moment, so that won't be for a couple of months. But thank you very much for joining us, and we will share all the resources in a follow-up email and links to the resources. Thank you very much. Yeah, thank you. All right.